Assalamu alaikum. Day long clinical day. First scenario, 25 years old female, Julia Adam, with history of skin rashes. Please take history, examine, and address her concerns. Okay, ready? Here you go.
Hello,
Hello.
I'm Dr. Ismail, Senior House Officer of Duty now. Am I talking to Miss Julia Adam and you are 27 years old?
Yes, I am Mrs. Julia Adam, and I am 25 years.
Okay. Welcome, Mrs. Julia. What may I ask? Today we will discuss your health issue and I will examine you and address your concern. Is that okay?
Yes.
Uh, what brought you to the hospital today, Mrs. Julia?
What brought me to the hospital? Because I have this skin rash. It is long time I have this rash, so it is disturbing me a lot.
Can you show me this rash?
Yes, you can see. I'll share the photo. Appear.
Yes, in the chat box now, you can see.
In the chat, okay.
Okay, Miss Julia, I'm sorry for that. We are hoping to solve this problem for you. You told me this rash for long time.
Yes, just appeared my period. It has appeared maybe after it by 1 year.
I'm sorry for that, Miss Julia. Apart from this side, any other site for this rash or only in the face and neck?
So there is some in my abdomen also, and some scattered in my chest, but this is mainly in my face, and as you see.
Okay, Mrs. Do you have any problem regarding this rash in the form of itching, oozing, or bleeding?
Bleeding from this rash, you mean? From
Yes,
my face?
from
No,
it,
from this rash, this in my
okay. Do you
face, I
have
don't have bleeding.
okay? You have bleeding from your nose.
Yes, I have.
When last attack?
1 month back.
Okay. And when it come, how much blood come from your nose?
Actually, I have not calculated. It is like spotting, and then it stopped by itself.
Mm. Um, how many episodes per month you have bleeding from nose?
It is not too much, maybe 3 or 4 times in the last year.
Okay, I'm sorry for that. Do you have any bleeding from any other orifice of your body?
No,
Any coughing blood?
no,
Any blood in urine, in water
no,
work?
no,
Any blood with back passage?
no.
Any throwing up blood?
Thrown up blood? No, I don't have thrown up blood.
Okay. Mrs. Julia, may I ask you, do you have any shortness of breathing?
Sometimes.
With exertion mainly or at rest?
No, I have not noticed, the doctor.
Okay. Do you get up from sleep by night gasping for air?
No,
Do you feel dizzy?
no.
Anyone told you that you are become more pale more than before?
Yes.
I'm sorry for that, Mrs. Julia. When this you feel that you are pale more than before?
Just my friend, she told me, and my husband Anderson also, he told me you become pale than before.
Okay. Do you notice that is there any swelling in your legs?
No,
Do you have headache?
sometimes.
When can you give more details about this headache?
Doctor, it is not associated by anything. Sometimes I have headache. I don't know because of the work at home, or I don't. I have no issues regarding this headache. It come and go.
Yes, it is throbbing in nature, or which type? Squeezing, or
You know, it is dull.
which side of your head suffers this headache?
It is temporal.
Okay, okay, okay. May I ask you, Mrs. Julia, do you have any family history of similar condition? Same rash, bleeding per nose in your family?
Yes, my nephew, she has some bleeding per her nose before also.
Mhm. And any one of your brother, sister, your father?
Mm, my father, no, I am adopted.
Okay, okay, okay. May okay. May I ask you, do you have any changes in your bowel habit?
No,
Any changes in your weight?
no,
Any rise of your body temperature?
no, I have not
Any,
noticed.
any lumps of bump in your body?
No,
Any shaking of your body?
no,
Any abnormal sensation?
no,
Any weakness in any limb?
no.
Any cough?
Cup?
Cough?
No, no,
Okay. Any joint pain?
no,
Any skin rash other than this rash? Photo
no,
changes
no. This is the same
in
rash I have
type.
also in my chest and the abdomen that you
Ah,
have seen in my face.
okay, 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 okay. Miss Julia, may I ask you, do you have any past medical history I should be aware of other than this bleeding and this rash?
No, just sometimes I took for the headache aspirin as over the counter.
Okay, okay. Any hospital admission before?
No,
Any blood transfusion?
no.
Okay, Miss Julia. May I ask you, Mrs. Julia, what do you do for living?
Actually, I am a house life. House wife.
Okay. How much is this bleeding? Yes. How much this bleeding in your nose and this rash affect your daily activity?
No, it's not affecting daily activity, but I am shy to show it to my colleagues and friends.
Hmm. I'm sorry for that, Mrs. Julia. When we form a team for treatment for you, I possibly involve specialized doctor to see you and how he can change this rash by any uh, by any mean. Okay.
Okay.
Mrs. Julia, do you smoke? Do you smoke?
Yes,
How many cigarettes per day? For how long?
3 cigarettes per day for the last 4 years.
I'm sorry for Miss Julia. Do you know that smoking is very injurious for health, and I advise to stop smoking. And if you don't mind, I will refer you to smoking cessation clinic. Okay?
Okay, doctor, I agree.
Hello?
Hello, yes. Yes,
Hello?
doctor, I agree.
Hello?
Hello. Yes.
Yes, we can hear you, Dr. Mahi.
Do you drink alcohol? Do you drink alcohol?
Only socially.
How many units per week?
No, only socially, doctor. When there is celebration, I drink. Nothing. I am not drinking.
Dr. Mahi, where have you been? Waiting for Dr. Mahi to join back.
He has a problem connection of the internet, maybe.
Yes, the same happened yesterday or day before yesterday. So we'll wait for him. I will message him.
السلام عليكم.
Alaikum salam.
Alaikum assalam. Go
السلام
ahead.
عليكم.
Yes, we can hear you now. Continue, please. He left again.
أيوه السلام عليكم.
Yes, Dr. Mahi, we can hear you. Can you
السلام
please?
عليكم.
Wa alaikum assalam. You can hear us? Dr. Mahi,
السلام عليكم.
you can hear us? We hear you, Dr.
Uh,
Mahi.
Yes. May I examine you? May I examine you, Julia?
yes. What do you want to examine?
Okay, I will examine. I will start from the hand first. Okay.
Okay.
I will see for any pallor in the hand. What about the pulse? There is pallor.
Okay. There is valor, yes.
Any any
Uh,
cyanosis in the hand.
no cyanosis.
Okay. What about the pulse?
Pulse tachycardia
Rapid
about
3D
95.
pulse or good volume or low volume?
It is good volume, but it is
Okay.
tachycardia,
Okay.
95.
Then I will go to the face. I will check for anemia in the pallor in the face. Okay.
There is valor, yes.
Then I will ask the patient to open his mouth, and I will, by torch, I will see telangiectasia Mouth, okay.
Yes, already you have seen that one. It is in the photo. Yes, the tongue you have seen.
Yes. I will ask him to raise his tongue to see any any cyanosis
No, no cyanosis.
in the dorsal. Okay, okay. Um, I will expose his
What you will expose? I think it is the connection again.
Yes, the same. Dr. Mahi, we can't hear you. Dr. Mahi. Okay, I will message him again.
السلام عليكم. السلام عليكم.
وعليكم السلام ورحمة الله.
دكتور محي.
اوكي I will continue examination. معلش يا باشا، والله باكت النت دي مش عارف حصل فيها ايه.
Okay,
أنا متأسف.
okay, continue, please.
We reach to the examination of the mouth for the telangiectasia. Okay. Then I will go to examine the heart also for any gallop, any murmur.
Normal.
I will check the apex also. The apex is displaced or no. Okay.
Normal.
Okay. Then I will auscultate the lung for any possibility of AV shunt also. Okay. Any Berwi over the lung fields.
Okay. No abnormality.
Okay. Okay. Then, I wanted to ask you, Miss Julia, about this headache. You told me in the occipital area, on the back of your head. Is that okay? Any
No.
loss?
It is the side
Where?
of my head. Temporal.
Side. But you did not lose any conscious level before?
No.
This headache, it increases when you are leaning forward or coughing or sneezing?
No. Never.
Okay. What is your concern, Mrs. Julia?
I recently married. Can I go for pregnancy? No problem with my condition.
I appreciate your concern, Mrs. Julia.
2 minutes left.
You have a condition named as hereditary hemorrhagic telangiectasia, mostly, and this case is named as autosomal dominant condition. Means about 50% of the generation or your kids will be affected with this disease.
Oh,
And the pregnancy is not contraindicated for this disease. But I will run for you some investigations, including a blood test, to assess how much this blood loss affect your general health. Because anemia with pregnancy is not favorable state, and we should correct this anemia before you get pregnant. Okay?
okay. You mean, doctor, that my children will be affected?
50%. Possibility 50% of your kids will be affected with this condition.
Okay, doctor.
Okay?
Okay.
Do you have any other concern, Mrs. Julia?
No, thank you, doctor.
Okay.
Dr. Mahi, how you want to examine the telangiectasia? How to examine it?
Only inspection.
Only? You cannot do any clinical test?
If I press it, it possibly
Yes.
not blinching, not blinching.
No, it's
Blinch.
blanchable. It's blanchable.
Blinchable?
Yes. Yes.
Okay.
Okay, let's start. Any other question you want to add? Or any step, clinical step, examination?
No, no, no.
Okay, time is up. Dr. Ahmed, can you start the clinical questions?
Yes. What is your differential diagnosis of this case and the finding?
This 25 years old young adult female has telangiectasia and epistaxis associated with anemia, and there is no evidence of heart failure.
Okay. What is the differential diagnosis in this case and the main diagnosis here?
Yes, main diagnosis, hereditary hemorrhagic telangiectasia.
Okay. What others can be? Okay. If
I don't
extended
know.
time of examination, what else you wanted to examine?
Examine the examination of the rash, examination of heart failure. This only. I should examine also the abdomen for any kidney or liver. It may be involved with this AV malformations, shunts, or AV malformation, yes. Can be the kidney or the liver. And should examine by palpation and auscultation also.
Okay. What investigations you wanted to do for this patient?
I will do general investigation in the form of blood test and to see CBC, how much hemoglobin, microcytic hypochromic anemia. Also to check platelet count because maybe differential diagnosis of other disease. I will also consult the ENT doctor to see the nose for any abnormalities in the visits. Yeah.
Okay. What treatment you can give for this patient?
I will do also echo to see ECG and echo to see if there is any dilated cardiomyopathy because of high cardiac output state. But against this, there is no heart failure clinically, or apex is not displaced. So,
How you explained the heart failure in this patient?
I asked about symptoms. There is no symptoms of heart failure. And by clinical examination, apex is not displaced and no functional murmurs. No, also signs, peripheral signs in the form of GVB or crackles in the lung. or edema lower limbs. So no signs of heart failure.
Okay, you examined the GVP. Okay. Okay. The main differential is hereditary hemorrhagic telangiectasia, as you mentioned. Okay, and the examination of the rash, as you said. Okay.
Treatment,
Regarding
treatment.
her medication, it can lead to this condition.
What is medication? I forgot to talk about medication history. What is the medication?
She was taking aspirin.
She said I take only because headache is infrequent, and she yes, she used aspirin. But I did
Yes.
not ask if she has allergy to aspirin or no.
Okay. 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 Excellent, Dr. Wahi. Excellent.
Still 1 minute,
Okay.
Dr. Ahmed. If you want to ask, or I will ask.
Okay. For this headache, you wanted to do any others investigations for her?
From the history and examination, it is simple headache. But if he has family history of sudden death or intracerebral hemorrhage, we will proceed for either CT with contrast or MRI. But he is adopted, and there is no dangerous signs indicating any aneurysm in the brain or EV malformations inside the brain. So,
okay. If extended time for you and you wanted to do neurological examination, one test for the upper limb and one for the lower limb, what you will do?
the lower limb, I will do plantar, and for the upper limb, pronotor drift or the power of the muscles.
Okay, excellent, doctor. Excellent, doctor.
For treatment, you wanted to ask me about treatment of
Yes.
anemia, and I will, for multidisciplinary team, I will consult the dermatologist for possible any laser for this telangiectasia. And also the ENT doctor for any exposed vessel in the nose for cautery or like this.
Okay, excellent.
You mentioned the radiological tests.
Dermatology.
For the brain.
Radiological investigation. Image.
Yes. Yes, imaging for the brain, CT with contrast or MRI. But if there is dangerous signs or any malignant history that this patient has positive family history of sudden death or intracerebral hemorrhage, so we can consult, do this test to exclude the aneurysm or EV malformation.
Other image, not the brain. Not specify the brain. Other body image.
Yes, I try to auscultate for any berwi
No,
over
investigation.
lung field to do if there is any malformations or cyanosis. We
How
can
to
do
diagnose the AV malformation by image? What image in the choice?
CT. There is two choices. First, we can do CT with CT pulmonary angio with contrast. This can detect any malformations inside the lung. We can do also
CT angio all the body. You have a lot of possibility of AV malformation, right? AV malformation. So CT angio is a diagnostic.
Okay.
Not specifically the lung. Yes. Okay. Thank you, Dr. Mahi. Now, Dr. Ahmed will comment. Then I will comment.
Okay. Actually, Dr. Muhi, he did great because he catched the patient. He diagnosis from the spot diagnosis of this rash. So excellent that he reaches the diagnosis. Regarding this case appeared before the last examination in Egypt, one of the carousel, it appeared as hereditary hemorrhagic telangiectasia. So he asked regarding the history, he asked regarding the nosebleed, and it was present. And the telangiectasia, this is the second character, should be present. Others, I tried to first. I told there is a nephew who has, and then I remember I told him adopted because this family history is one of the criteria. Also, can be diagnostic. There is also the visceral lesion, so I gave him a clue regarding the headache and the shortness of breath because it can be on the brain or the lung, the AV malformation. So to make a definite diagnosis, three or more criteria should be fulfilled. Possible or suspected two criteria are present, unlikely one or none criteria. The criteria are four. If three present, this is definite. One of them is epistaxis. The second is the telangiectasia. The third is the visceral lesions, GIT or lung or brain, liver. And the fourth is the family history. Three of them is enough for the diagnosis. So he did great in the taking the history. Regarding then the examination, I think in the examination, even focus the examination in the long case, the general examination is important, including the GVV, because this patient is complaining of shortness of breath. Maybe she has pulmonary hypertension. Okay. So the symptoms of this hereditary hemorrhagic telangiectasia, the nose bleeds. Maybe there is low blood pressure. He should ask regarding all the vital signs, not only the pulse. He can tell the examiner, give me the vital signs and the body mass index. Okay. The red dots on the skin, pain, swelling, or numbness. There is unexplained bleeding, the iron deficiency in anemia. He asked regarding migraine and headache. Also, maybe the pulse rate is tachycardia. Shortness of breath, maybe symptoms of heart failure or some convulsions. It can occur. Then regarding, he answered the concern good because it is autosomal dominant. As he said, 50% of the children can get this condition. He can add that if you need to get pregnant, this should be planned by the woman doctor. This is better to add to in the concern, I think. And in the treatment for the hereditary hemorrhagic telangiectasia, the most important is to discover if there is any emergency to deal with, as Dr. Bassem said regarding the CT angiography, and if there is brain headache, she should undergo CT brain. Even without contrast, the bleeding will appear. Also, there will be treatment for this iron deficiency anemia by iron supplement according to her hemoglobin level. Regarding the nose bleeds, it should be by the ENT if needed laser therapy. And also for the skin telangiectasia by the dermatologist, also by laser. Inside the body, this can be by the coagulation or embolization. It can be done for the lung. For the brain, we can go to for stereotactic radiotherapy or also according embolization or what available to be done. Okay. The investigations also include the CBC chemistry, and also he should undergo all the bleeding time, BT, BTT, all these things should be requested. Okay. Regarding the differential diagnosis of bleeding, also came in basis. It can be bleeding either in young age or old age. In young age, hereditary hemorrhagic telangiectasia, maybe hemophilia or von Willebrand, and the clinical picture will be different. Okay. In older people, it can be ITB or leukemia or even myelofibrosis, sometimes drug toxicity like warfarin. Okay.
So, sorry, Dr. Ahmed, you mean by differential diagnosis of bleeding or for telangiectasia itself?
In this case, the bleed, she has a bleeding.
Yes,
Okay, you
yes.
will see her age is young. She's 25 years, so you can add hemophilia, von Willebrand. Add the causes of bleeding present in this case. You can tell hemophilia, but if hemophilia at this age, mostly she will receive the factor 8 or she has hemoarthrosis. This von Willebrand mostly she has monoralgia since the start. Also will be like this hemophilia, the picture like this. Okay, old age.
Yes,
Yeah.
yes, but von Willebrand and the
Yes.
hemophilia, they don't have telangiectasia, صح? ولا they have
Yes, yes. I guess you'll tell the
they,
examiner against this there is no telangiectasia.
again
Yeah,
But
yeah.
when will
Will tell
brand
there is bleeding
hemophilia
like
will not be presented with epistaxis, right? Von
yes,
will brand maybe.
yes. So
okay.
you'll tell like this.
The
يعني
age malignant.
you'll think of causes of bleeding, you know, and he will tell against this like that one only. Because I think they told us you should have 3 or 4 differential. It is will be stressful really to think
معلش انا
regarding
حصل
the
لي
differential just to finish
أيوة.
the but you did great really. Yeah. Excellent that you
صحيح
catch
انا
the
حصل
case.
لي منتال والله حصل لي منتال بلوك حصل لي منتال بلوك وما عرفتش اجاوب على الديفرنشال دياجنوز.
No
What
problem, Dr. Mahi.
yes.
But as mentioned in the chat box, I prefer to be asked the examiner what differential you want for. Is it for the telangiectasia and rash or for the bleeding? Because for the telangiectasia, I think
yes.
it will be different. But for the bleeding, okay, but this patient presented with rash. So the complaint is rash. Or you can ask the examiner what differential you want me to give you, either for the telangiectasia itself. So as mentioned in the differential, you can mention the ataxic, the telangiectasia, and so on. But if he asked you for the whole diagnosis, HHT or hemorrhagic, hereditary hemorrhagic telangiectasia, as a cause of bleeding, you can mention the bleeding tendency, other congenital cause of bleeding tendency, like von Willebrand and hemophilia and so on. But it depends on the examiner question. So you can ask him what differential you want and give him accordingly. Okay? This is regarding to the differential. Let's start with the history. I think, yes, it was spot diagnosis from the picture, but I prefer to ask about any previous attack. Did you have it before or when it exactly started? Because it would be since earlier or childhood maybe. And the other thing, the good thing also here, Dr. Muhi analyzed the headache because it's alarming. Even he told you or she told you the headache is less severe for me, but it would be an alarming if it was AV malformation headache or something will be like subarachnoid hemorrhage as rupture AV malformation. So it's good and it's wise to analyze it well, as Dr. Muhi did, even at the end, to roll it out. And you can give safety netting at the end regarding this. If you have a severe headache, that it's the worst headache ever, please call your GP or come immediately to the emergency. Why? Because this patient is susceptible to have rupture of this AV malformation, particularly if he is or she is hypertensive, but supposed to be also managed earlier as a prophylactic if there is AV malformation in the brain. So they will not wait for hair to be ruptured if it is significant and there is AV malformation in the brain. That's why the investigation should be completed on the presentation. This is regarding to the history. Other history, I think, Dr. Muhi, you missed the female history, the period, the bleeding. It's important to ask about. Although you ask any bleeding from any area from your body, but there is specific question for the period because this is female in the childbearing period. Did you ask?
Yes. No, I forgot.
Exactly. And the aspirin as well. It's one of the blood thinner medication. Once you hear it, you should analyze and you should address it. She take it for a headache, but there is other option, and she take it an over
Yes.
counter. So please stop it immediately. Please, if you want to take any medication, should be prescribed by your GP. Aspirin might lead to more bleeding. She has already nosebleed or epistaxis. The aspirin will make the blood more thinner and she will have more bleeding, right? should be addressed. And don't forget the question of medication list. You should address the all medication. It might have some effect on the bleeding. And the aspirin, already mentioned by the surrogate. Don't take anything lightly. If she told you, doctor, I am taking aspirin for headache, and you just skip it will harm your mark. Particularly if she mentioned it, you should take action immediately. Not only the aspirin, any medication the patient is taking. Okay, this is in the future. I mean. The examination, I think you did the all examination steps, but the leukonychia is possibly to be here, right? Leukonychia, as iron
Yes.
deficiency. I mean. You examine the pulse, but in the same hand, you can check for a leukonychia. The heart failure signs, as Dr. Ahmed mentioned, raised GVP, bibasal crackles, and the lower limb edema. The job here, I don't know if you ask. She said housewife, right?
Yes.
Okay, so you address it. The last thing, yeah, I want to add the echo with bubble study. This is the preferred and recommended test for the respiratory or the lung AV malformation, not CT
Yes.
pulmonary angio. Okay, it can detect initially the AV malformation in the lungs. But CT angiography, the choice that the investigation of the choice, it will show you a lot of AV malformation if there is. Don't forget to offer digital rectal examination. Some patients will have angiodysplasia, and they might have, and you can ask particularly bleeding bare back passage. Sorry for this question. I think this is the most important advices regarding this case. And be specific in your answer. 50% in every child to have the disease, not 50% of your child or of your children.
Every child.
Yes, please be specific in the autosomal dominant condition. It would be 50% for each child. So the first baby, he have or he has possibility of 50% to have the disease or not to have the disease. The next one will be the same, 50% to have or not to have. And you can refer this patient for genetic team for genetic selection in the future. She give you good opportunity to talk about this. She told you in the concern, I want to be pregnant. So please, I will refer you to the woman doctor, as well as our genetic counselor team to sit with you regarding the transfer of this gene to the babies. In order to have a safe baby, we might do some tests, including the genetic testing. Okay, this is one of the concern. And please reply according to the concern. She asked you, doctor, I am planning for pregnancy. You told her you have a condition called, she didn't tell you what I have, doctor. So answer as she asked or according to the question. What she asked about, answer it. What I have, doctor, okay, address this by telling the name of the disease and explain it. But the first concern was, doctor, I am planning for pregnancy. What should I do? Now you can tell her, I will refer you to a team, including the woman doctor, along with genetic team, to have a safe baby and a safe pregnancy. Because this disease is running in the families by 50%. Now she will ask you, doctor, what is this condition? But don't give the answer of the something that she didn't ask. Okay?
Okay. Okay.
Okay. Any question, Dr. Mohi, Dr. Ahmed?
شكرا. Thank you.
Any question from
Thank you.
others? Dr. Mohi, please write your case scenario.
Okay. Okay.
We will have the discussion now, open discussion. Anyone has comment, suggestion? Any question? Okay, some comments Dr. Marwa wrote. Brain, lungs, GI, AV malformation should screened in history and investigation. Exactly, we mentioned it. By the way, it's one of the criteria. Nosebleed, the first. The second, AV malformation, either liver, lung, or brain. And the third is telangiectasia, face or mouth. And the fourth is family history. 3 out of 4, it will be conclusive for the disease. Since this patient is adopted, you can refer for genetic testing. But family history is enough. Okay, Dr. Ahmed, your scenario, Mrs. Jennifer, 33 years old female, presented with vomiting, abdominal pain, hypotension for 10 hours. Seems like acute condition. Prepare yourself, then we will start. Dr. Marwa also wrote in the differential ataxic or ataxia telangiectasia, both Jigger's disease and steroid induced are differential. Okay, accepted. Again, according to the differential or to the examiner question, differential of the rash or differential of the disease. Some examiner prefer to ask as a differential for the complaint. So you will answer according to the complaint. If they ask about the others of the condition, you will answer according to the diagnosis. Dr. Ala wrote CREST syndrome. Maybe because of telangiectasia, you mean, but the telangiectasia of CREST will be in the hands, not in the face. And CREST syndrome, it would be differential for another disease, not in this condition. I guess nothing here related. Only telangiectasia, and it's in the hands. Yes, Dr. Mohi. Sorry? Anyone talking? Hello?
إضافة بسيطة بس دكتور باسم بيحبوا يسألوا what is
Yes.
the
Sure,
differential
doctor.
diagnosis
Yes.
الله يسعدك what is the differential diagnosis of telangiectasia in general
Yes.
فبيحبوا فيعني الواحد أوكي الكريست صح لا بس لو سألوا على التلانجكتيزيا بس لحال
Okay.
فسكليروديرما تلانجكتيزيا
والله
روزيشيا
كنت عايز أقولها
الستيرويد
بعدين في حاجات
الستيرويد induced
Okay.
بيحبوا كتير الستيرويد induced حتى الواحد أحيانا بالهيستوري of any telangiectasia مفيد يسأل إنه have you been on any medication like steroid بالاسم يعني
Okay.
فالروزيشيا سكليروديرما الستيرويدز وعندنا ال H الهيريديتري هيموراجيك ال HHT
Yes.
هذا كمان ضاف الاتاكسيا تلانجكتيزيا يعني بالنسبة لنا هدول الخمسة ديفرنشيال بس طبعا مو للكيس
Yeah.
للسكين ليجن لايك تلانجكتيزيا طبعا الكيس
Okay.
صعب انك تقول روزيشيا او سكليروديرما وانت ما عندك سكليروديرما فيتشر
Mhm.
لكن كتلانجكتيزيا من السكين ليجن يلي لما بتجي بالامتحان تنسأل عن الديفرنشال دايجنوسيس تبعها in general as a skin lesion يعني وما ننسى دائما ندور عليها بالهيدن areas يعني بالذات اللي منكم الامتحان تبعه بيوكي فيفضل انه ما حيلاقيها هيك في الوش يعني يا دوبك يلاقيها بالبالمز او بالبلانتر سيرفيس تبع الفيت او inside the mouth under the tongue يعني
Mhm.
بأماكن كتير هيدن فبرا لأنه بيستخدموا الليزر سيرجري ف you should be very meticulous when you are looking for the telangiectasia especially if you suspected وشغلة تانية شو رأيكم راجع ال causes of epistaxis عادة نحن عنا ميول إنه لما نسمع epistaxis فورا بيروح بالنا لل HHT
Mhm.
فشو في differential لل epistaxis other than HHT
Yes. Any volunteer? Dr. Mohi, what do you think the causes of epistaxis in paces? We mentioned it maybe with hematuria.
راجعتوها طيب أوكي نعيدها ولا راجعتوها
Yes,
كلها
yes, yes. Let's
فاسكولايتس
revise.
راجع
رقم
طيب
واحد
Sorry?
فاسكولايتس
Okay.
الفاسكولايتس ويجنر جرانيوماتوزيس واحدة من
Perfect.
ضمنها
This is this is the most important, yes, to rule out. Exactly. GPA.
جي
Okay.
بي اي وعنا شو كمان
What else?
medication
Hypertension.
induced حالات
هايبرتنشن وبيحبوها كتير مع الكواركيتيشن، لأنه الكواركيتيشن
Coarctation, yes.
بيعمل very severe hypertension بالupper parts، يعني
Exactly.
بالupper circulation. فبتلاقي البيشنت البلاد بريشر تبعه يعني 100 135، مو عالي، لكن عنده ابيستاكسس بسبب هالفرق بالبلاد بريشر. فالابيستاكسس بالكواركيتيشن وبالهايبرتنشن ان جنرال. وين كمان بنشوف الابيستاكسس؟ ويجنر قلنا صح، كمان مع الهايبر فيسكوسيتي سيندروم.
Yes.
يعني حتضيعك لو انت ما ربطتها مع الهايبر فيسكوسيتي مع هيديك ومع فيجن بروبلم، حتقول انت هايبرتنشن، هي حتكون مالتيبل مايلوما او بوليسايثيميا روبرافيرا او هايبر فيسكوسيتي بسبب اي kind of hematological malignancy. فالإبستاكسس يعني very tricky و you should really consider ال HHT ويجنر hypertension especially coarctation. يعني وقتها عن جد اسأل على الراديو راديال والراديو فيمورال، لأنك صعب تلاقي الكواركيتيشن بأي ساينس تانية. والهايبر فيسكوسيتي، لأنه الهايبر فيسكوسيتي بتشارك كتير سيمتومز مع الهايبرتنشن، فأنت إذا ما خطر ببالك حتروح عليك شغلات مهمة بالهايبر فيسكوسيتي. الاثنين بيعملوا هيديك، الاثنين بيعملوا بليرنج اوف فيجن، الاثنين بيعملوا ابستاكسس. تمام. فتيك كير اوف ذس سيمتومز. طبعا عندنا الابستاكسس اللي هو بليدنج مع البلاد ثينر، مع التروما، مع البليدنج ريسك اللي هي مثل الريكريشنال دراجز. تمام، بالذات البيبل who are taking recreation by sniffing. فيعني هي بقى الريجولر بليدنج ريسك فاكتور. تمام. فبس هذا اللي خطر ببالي.
Local causes as well. Yes. We should
ايوه
rule
عليك
out.
نور اللوكال كوزز اللي هي ما تعتبر سيستميك يعني.
Yes. Venwell brand, دكتورة هند, we didn't mention. It's a common cause.
فهو البراند I agree معك، اللي هو البليدنج from any orifice. يعني أي شيء بيعمل لك هاي بليدنج ريسك
Yeah.
حيعمل لك gum bleeding
Exactly.
ومينوراجيا وكمان
Yes.
إبستاكسس. فدائما لما بتلاقي إبستاكسس قال bleeding elsewhere، حيطلعك من دائرة الإبستاكسس للسيستميك bleeding. أو لو ما لقيت أي bleeding elsewhere فقط إبستاكسس، بدك تفكر بالفايف كوزز اللي قلناهم، اللي هو ويجنر، اللي هو هايبرتنشن، اللي هو هايبر فيسكوسيتي. تمام، اللي هو الاتش اتش تي. لأن هو
Yeah.
الاتش اتش تي بيعمل bleeding elsewhere، بس يعني أغلب الأحيان الأوفيس bleeding حتلاقيه إبستاكسس بلس أنيميا. تمام.
Exactly.
يعني مو دائما بيكون عنده bleeding بيركتم ومثلا AV malformation بالجي اي تي فعنده كمان هيماتيمسيس. اغلب الاحيان ابستاكسز وانيميا. وتيلانجكتيزيا مخبايه هون وهون يعني. فتيك كير اوف انه لوكال بس ابستاكسز، ولا انا عندي سيستميك بليدنج. فمن البدايه اسال بليدنج elsewhere، حتى مثل ما انت قلت، يا حتحطك in front of blood thinner وفون ويل براند و other bleeding risk factor systemic causes، أو حتحطك قدام local bleeding بس بالنوز، أو بالأحرى مو local بس بقصد يعني causes of bleeding from the nose only. تمام.
Yes. Thank you, Dr. Hind.
الله يسعدك يا رب.
Thank you so
موفقين.
much. Yeah, thank you. Dr. Goda add also camera test endoscopy. Yes, this is for GI endoscopy, for GI bleeding, AV malformation as well. Occult blood in stool, exactly. Melina should be asked. So any bleeding or yes, black stool particularly as a question. APC for AV malformation, epistaxis, liver disease. Okay. Any bleeding disorder, ITP. Yeah, it would be again systemic bleeding. Okay, let's start. Dr. Ahmed, ready?
Yes.
Yeah.
Okay. Hello. Hello.
Dr. Mohi, again.
We problem with the connection also.
When we need him, he is disappearing.
Yes.
Dr. Mohi, please answer this hello. I think he's out. Okay. Let's have another discussion until he will join back. We will reset the timer. Anyone has a comment, suggestion? Dr. Goda, I will ask you, what is ABC? ABC for AV malformation. APC. I didn't get it. Okay, anyone has suggestion? By the way, this patient, as Dr. Hind mentioned it, she will come with epistaxis. This is one of the possibility, and she will tell you, yes, I had a laser or I had surgery to my nose. So if you find the telangiectasia, maybe some of them will be underwent the laser. So she will tell you, I had history of sepsis, but now it's improved or disappeared because of the intervention. So don't be panic. It's not the case. No, it might be the case with smart intervention or technical improvement, but after surgery, it would be disappear. Liver disease also can cause, yes, any bleeding tendency from anywhere, the same as warfarin. So you will find again the bleeding from every part of the body. Coagulation profile is the must. You will find all the bleeding tendency profile affected. Increased INR, increased PT, increased PTT. Fibrinogen also might be low.
In hereditary hemorrhagic?
No, I'm talking about liver disease.
Yes.
By the way, hereditary hemorrhagic telangiectasia, the whole bleeding tendency will be normal.
Yes.
The whole bleeding
Because
profile.
it is only malformation. You talk
Yes.
about the treatment and or the management of this condition?
Yeah, we talk as multidisciplinary team, including the ENT, including the gastro, the pulmonologist, thoracic surgery, specialized nurse.
Yes, it's the most common site is the lung, and we should embolize even if no complication.
Yes. So this is as intervention or surgical option.
The liver also, if there is liver malformation, they also making embolization because if they
Yeah.
left them, high cardiac output failure will develop, and the pulmonary hypertension also. So they
Yes.
embolize even if no symptoms. So we will search about them and embolize them.
Mhm. Perfect.
About the epistaxis, it's the most important symptoms and the most common. So maybe he will talk about the epistaxis alone. It can be life-saving if it is massive bleeding. So some people need the blood transfusion in epistaxis.
Exactly. Yes.
So backing and educate the patient and using of lubricant always to the nose. So he will avoid the bleeding. This is should be advised in non-pharmacological management.
Perfect. The heat here also exposure might lead to the bleeding, as usual,
Yes.
as any cause of epistaxis. So we can give also some advices regarding
Yes, and
heat
prolonged leaning forward, exposure to high heat, and also to be more in severe anger, to raise your voice loudly. All these things may be also advised,
training.
especially if it is communication. Yes.
Yeah. Okay. So again, it's a multidisciplinary team approach because the bleeding comes from multiple systems, plus some pharmacological. I think here no specific pharmacological therapy, but the
There is
most
some
important.
really, but I think it's not very famous. But it's
Yeah.
something also that reduce the progression of malformation, some sort of chemotherapy, like used in multiple myeloma and something like that.
Okay.
We can mention only there is new modalities, medical treatment under experiment or like this.
Okay.
But now they trying some medication really. But
I
it's
think
like
Dr. Muhi
chemotherapy.
answered.
Sorry, Dr. Ahmed.
Dr. Muhi, I think was us.
No. Yes, he's yeah. Dr. Muhi, we cannot hear you. I think still he has a connection problem because the mic, even the mic, we cannot see the mic in his name or beside his name. Disconnect and reconnect back, Dr. Muhi. We are waiting for you. If you are unable, we can give this case to someone. He can be volunteer for Dr. Ahmed. I will message him. Continue, Dr. Aisha, if you have something to mention.
No, just this point is about non-pharmacological is the most important.
Exactly. Always
Wear
start.
protective clothes outdoors, avoid sun exposure,
Yeah.
using sunscreen, using lubricant to your nose in the summer.
Mhm. Of course, avoiding also the straining, sports,
Mhm.
heavy exercise. All the things also might lead to bleeding easily. So it should be avoided. Usually, and it's advice, start with the non-pharmacological. Counseling education is very important to spend the time talking about them. Then you can go to the other option, either surgical or medical. In this scenario, surgical option or the radiological option, embolization, one of the options should be considered.
It can be called that is differential here systemic lupus or no?
Systemic lupus as a cause of
Because
vasculitis.
it can cause telangiectasia or
You mean the malar rash in the face?
Mm.
But it's different, I think, in the
Mm.
but even the rash will be non-blanchable, I guess. But here it's blanchable.
And not crest also like also
Yeah,
telangiectasia.
yeah, there is telangiectasia and crest, so we can mention it.
Mhm.
Any telangiectasia, you can name it as a differential. But again, as a differential of telangiectasia, not as the bleeding tendency. But anyway, this is we are giving differential for the disease. So telangiectasia as a name, we can give ataxic telangiectasia or crest. Okay, waiting for Dr. Muhi still, he didn't join. I messaged him as well. If he can give us the idea of the scenario, then someone can be volunteer. It's interesting case. I guess it's nice case because acute presentation within hours.
يا رب بس النت يا باشا ما يقطعش والله.
Okay, Alhamdulillah.
يا رب
Please.
بس ما يقطعش. يلا بسرعة
Yes,
دكتور.
I hope. Yeah. Okay.
والله واقف على
Continue.
حيل.
Yeah,
واقف على
start
حيل.
before the connection will be
Oh,
lost. Yeah.
okay.
There you
Let's start. Hello.
Hello.
Hello. My name is Dr. Ahmad, one of the medical doctor. Could I confirm that I will speak with Mrs. Jennifer, 33 years old?
Yes, yes. Yes, I am doctor. Yes, yes.
Nice to meet you. Today we are going to discuss some health issues related to your health. I will take history, examine you, and address your concern. Is that okay with you?
Okay, doctor. Okay, okay.
Okay. First, I need to take all the vital signs of this patient and the body mass index because there is hypotension. I don't know what is the blood pressure.
Yes. Okay. Blood pressure is 90 by 55. Pulse is 95. Temperature is 37. Respiratory rate is 21. Body mass index is 30.
Body mass index is 30. Okay,
Okay.
and they are given now IV fluid or saline given for her for this low blood pressure. This is important. Okay.
I don't know. You wanted to start normal saline?
Yes, until we will see if there is
Okay.
because she's hypotension 90 over 55 now. Okay, so first, okay, it came to my knowledge that you are complaining of thrown up and abdominal pain and also this low blood pressure. Can you tell me more about this?
Yes, doctor. About 3 to 4 days, I'm not good. But today, few hours back, I feel very weak and I have headache and I vomit twice. And I have tummy pain in center of my tummy. It is severe and increasing with the time.
Okay. So regarding the headache, this is the first time or it has occurred before?
I usually have headache for longer time, yes, but and sometimes I use painkiller, yes. But
Yes.
I think it's because of my blood pressure. It was a long time, it is uncontrolled high. And
Okay.
today, the nurse told me blood pressure dropped. I don't know what is going on.
Okay. What medication you are taking for the blood pressure? You diagnosed with a high blood pressure, you told me.
Yes, I has blood pressure. I have blood pressure, yes, and I take 2 medication for blood pressure.
What is this medication?
I receive telmisartan 80 milligram, and I use also amlodipine 10 milligram for 1 year now.
For 1 year. And when you last took this medications?
I all the time take this medication, but about few days back I did not take it because I was very ill.
Okay, we should stop now this medication because of the low blood pressure. Okay.
Okay.
Okay. So this headache, where is in your head? Where is the site of this headache actually?
Today in front of my head.
Okay. This wish was associated with the thrown up.
Yes.
Okay. You have blurring of vision?
No.
Yes.
No blurring of vision. My vision is okay.
Okay. Okay. This thrown up also started when 4 days back only? Not has occurred before?
No. Today about 10 hours or
Today
12 hours now. I vomit twice. Yes.
Okay. This vomiting associated with blood?
No blood.
Okay. Tell me more about this abdominal pain. It is the center of your tummy. You told me. Anything increase it or decrease it?
Yes, it's first time for me, doctor. Yes, it is first time.
Yes.
I'm not
Any
sure for
factor can
that, doctor.
increase?
Just a few
Yes.
hours back it started. I think, first time. What? Nothing. I don't feel anything increased or decreased. But it is
Okay.
worsening with time.
Worsening with time. Okay. The severity, can you give me from 0 to 10? The 10 is the most severe, 0 is less from or 1?
It is about 5 to 10, doctor.
5 to 10. Any sites of
About
the
5 to
body?
6. 5 to 6.
Okay. Any sites of your body have this pain or only in your abdomen? It
Sorry?
is referred to any site on your body? This pain, it is referred in any other sites in your body?
It
I
is in
think
the center. It is in
yes.
the center of my tummy. Center.
Okay. No other parts. No other parts of your body has this pain.
In the epigastric. It
Okay.
is in the center of my tummy.
It started when?
Okay.
When it started?
Hello?
Hello. Yes. When it started, Dr. Mohi, is it, Mrs. Jennifer? I think there is misconnection.
Not referred anywhere. It is in the center of my tummy. In the center. No. In the center only.
Okay. When it started?
In the center of my tummy only.
Okay. Do you feel dizzy when you are going from sitting to up to stand? Any dizziness? There is something in the internet, I think.
Yeah, I think his connection is dizzy.
Yes, even he heard me after a lot of time answering a previous question.
Yeah, this is the sign of dizziness of the internet. Dr. Mahi, can you check your internet, please?
Dr. Muhi, is in Egypt or Saudi Arabia?
I think in Egypt.
Mm.
The nature of internet in Egypt. I don't think Saudi Arabia have
Yes.
such internet. We will wait for him. Dr. Mahi, did you join? I'll message him, sorry. Dr. Mahi, you can join back. Hello, Dr. Mahi?
يا أخي والله متأسف ليك.
Okay. There is any you feel dizziness while from going from sitting to standing? There is dizziness?
Yes, Dr. Ahmed.
Yes.
Dizziness, no dizziness.
No
Today or
dizziness.
what? Before? Today?
Before or yes, before also and today.
Before, no dizziness. But today, I did not walk. I cannot walk. I think, yes, it is present. I cannot stand up or go because of blood pressure is low and I am also my muscles all are weak.
Okay.
Huh?
Okay.
Hello, continue.
Okay. You have any other yes. Do you feel sick? You have difficulty of swallowing. You hear me?
Yes,
You have difficulty of swallowing?
yes, Dr. Ahmed.
Yes. Okay. Since when started this difficulty of swallowing? Since when started the difficulty of swallowing?
I think he's again,
He's again outside.
yes. If he give the scenario to someone else, it will be better.
I don't know the difficulty of swallowing. Yes, or he's hearing me
Yeah,
saying yes.
I think he said yes, but
Mm.
still need to be analyzed more. Wait.
السلام عليكم.
عليكم السلام.
السلام عليكم.
عليكم
معلش يا
السلام
دكتور
يا
أحمد،
دكتور.
كمل خلاص.
Okay.
كمل
You have a
كمل.
difficulty with swallowing, you told me when it started?
No difficult swallowing. No
No?
difficult
Okay.
swallow.
Okay. You have any changes in your bowels?
No.
Okay. You have any bleeding from any orifices?
No.
No bleeding. Okay. Do you have fever?
No.
Okay. Any sweating?
No.
Any weight changes?
I have, yes, my weight is increasing for 1 year now. I put on about 5 to 6 kilogram in this year.
Okay. What is the distribution of this weight?
Whole my body.
All your body. Okay. Sorry to ask, do you snore? Any
Yes.
food commented on this? Yes.
Yes. Recently, yes.
Okay. Do you feel sleeping at morning? Working
Oh,
hours?
no.
Okay. Any weather preferences?
No.
Okay. Any change in your water work?
Recently, no. But before, yes, I have some changes in my water work. It was dark and it was frosty also.
It was dark and frosty. You asked medical advice at this time?
Yes, this history 2 years back, I had fever, raised body temperature, and I have dark urine, and it was low amount, and I seek medical advice, and I was admitted to the hospital, and they started for me medications, and I continue these medications for a longer time. And this water work improved, and my water work become good.
Okay.
But later on, my blood pressure become rising, and also I develop rise blood sugar, and I start medication for both of them.
Okay. What is the diagnosis for you in this condition by the doctors?
I'm not sure,
And
doctor,
what
but
medications they give you? You don't. Okay.
they gave me medication named cyclophosphamide, 50 milligram. And since I started this medication, my condition improved really. My water work improve, and this rise body temperature improve also. And my feeling tiredness and
Yes.
fatigue improve also. Okay.
Okay. This blood sugar, what medications they give you?
I use oral tablets or medications in my mouth, metformin, gliclazide, and by Guardians 10 milligram also.
Just to confirm, you told me you are taking tilmozertan and amlor, and now
Yes, for
metformin and
hypertension.
gliclazide. Any other medication I should be aware of?
No, this is the medication. Sometimes I
Only,
use
yes.
painkiller for headache, for body ache, like this.
Okay. Any change of the dose of medication or recent medication added?
No.
Okay. You have any skin changes?
No.
Any joint pain?
No.
Okay. Any muscle weakness?
Yes, I feel all my muscles are weak. It was weak last year, and a few days back, this week, I become feeling tiredness, lack of energy all the day. And
Okay.
yes.
Yes. You notice anything increase this weakness?
I'm not sure, but it is worsening. For 1 week now, all my muscles become weak. my bone, also bone ache, like this.
Okay. Okay. Any bus medical history I should be aware of?
Yes, this what I told you 2 years back, that I feel rise body temperature and dark urine. By the way, doctor, dark urine started also this 3 or 4 days back. Also, it come back again.
So from 4 days, you have also dark urines.
Yes, yes. Dark urine and the low amount also.
Okay. You have any cough?
No cough.
Okay. Any shortness of breath?
No.
Any history of fits?
All the time I am sleepy. For 2 to 3 days back, I'm sleepy. So I don't feel any shortness of breathing while I'm sleeping. But I think if I walk and I go outside, maybe shortness of breathing can come. I don't know. But I'm comfortable at
Okay.
bed.
Okay. Any family history has this condition?
No.
Okay. Any diseases run in your family?
My mom has raised blood sugar, and my father has hypertension also.
Okay. What is your job?
I am secretary.
Okay. How much is the symptoms impacting your job and daily activities?
Yes, since 1 week now, I did not go to the work, and I am sleepy all the day, and I'm feeling very tired. So I did not go to the work.
Okay. We will try to provide you by sick leave by the occupational health they can provide. Okay. Do you smoke?
2 minutes left.
No, I'm not smoking.
Oh, okay. Can I examine you?
Yes, yes.
Okay. Abdominal examination.
Yes, there's tenderness in the epigastrium area.
Okay. Any organomegaly?
No.
Okay. Also, I'll go to for the general examination, jaundice with cyanosis and pallor.
Yes, patient looks pallor and no jaundice, and he looks toxic also, weak.
Okay. Okay. Also, the GVB raised or no?
No, no, she is hypovolemic. No raise of GVB, and they looks dry tongue also.
Okay. I will auscultate the heart.
Nothing is significant.
Okay. Any recent travel history?
No.
Okay. Sorry to ask, your periods are regular?
Yes, regular.
Okay. Any pills you take?
No, no. I don't have partner.
Okay. Okay. So what is your concern?
Why, doctor, I have this problem? Why? What happened
Okay.
to me?
Actually, from the history and the examination, we will still wanted to run some tests and further imaging, and we will tell you by another meeting regarding the diagnosis. We should stop the antihypertensive medication now, and we should do for you this examination also of the your water work to know what is the cause of this darkness. Okay. The visual
Okay.
acuity is okay for this patient?
Yes, normal.
Vision?
Yes, vision is normal.
Okay. Heart also normal? Chest,
Yes,
heart and chest?
yes,
Okay.
heart chest all are normal. Yes.
Okay,
Okay.
time's up. You can start examining questions.
يا باشا انت ممكن تديله دقيقة ولا 2 كده عشان
Okay. What else you want to ask?
عايز تسأل على حاجة يا دكتور أحمد
Any
اتفضل.
specific question you want to ask, Dr. Ahmed?
Any questions, other questions? Because of this headache also, I should do even the pronator drift, even, or the plantar. Anything?
Normal, normal.
Okay.
Mm.
So
Anything
Okay.
in the examination, anything in the history you wanted to ask? Because internet يعني اتقطع
Yes,
عليكم.
a lot
اتقطع
of
لك.
time lost. Even Dr. Bassem, he stopped, but many I asking the question multiple times.
والله متأسف لك يا أخي والله متأسف لك.
لا, no problem.
No worries. If you want to add 2 minutes, Dr. Ahmed, to repeat some questions, it's okay.
يعني خد راحتك خالص والله مش مهم الزمن بقى.
Okay.
Okay.
Try
The
to.
muscle weakness, yes. The muscle
Yeah.
weakness, you told me, started also long time.
In the first year, yes, it was there, but last year it was okay. After they started for me medications and treatment, I become good. But it come back in this 3 to 4 days back. Muscle ache, generalized fatigue, lack of energy, sleepy all the time. And
Okay.
uh,
Okay. You don't have weather preferences, you told me.
no.
And there is no change in your hand size or foot size.
No.
Okay. Let's start examiner questions.
Okay, doctor, what present your finding? What are the positive findings in this case?
This lady, 33 years old, presented with vomiting, abdominal pain, and hypotension. She is receiving antihypertensive medication in form of telmozertan and amlor. And also, she has a headache, she has muscle weakness and fatigability. She has a history of condition, and she received correct cyclophosphamide, and she has history of dark urine and proceed. I forgot to examine the lower limb. Okay.
Lower limb is normal.
Okay. She has also a history of snoring.
Yes.
She doesn't have any family condition of this issue. Okay.
So after this positive finding, how can you reach to any diagnosis? What do you think any diagnosis in this case?
Regarding the abdominal pain and the dark urine, maybe she has a condition of acute intermittent porphyria, maybe.
Acute intermittent porphyria?
Yes.
Okay. Why patient receive cyclophosphamide? Do you think? What do you think? Why patient is on cyclophosphamide medication?
Also regarding her this dark urine and procy, we should do analysis for this dark urine if there is blood in this urine.
Yeah, zero dark urine means blood urine.
Yes.
Microscopic hematuria.
Maybe there is hemolytic uremic syndrome. I should.
Okay. Hemolytic uremic
Further.
syndrome, acute situation, and it continue cyclophosphamide for 2 years. I'm not sure Dr. Bassem will answer this question. Okay.
Yeah, good question. It's not, no, it's acute condition.
Yes, acute condition. Yes.
Yeah, so another condition should be there.
Okay, doctor. Okay, now it is vague case, so we wanted to run some blood test and some imaging to narrow the differential diagnosis. So what you will do for this case?
We will do for her ultrasound abdomen.
You will admit first, sir, and start normal
Yeah.
saline to support the circulation.
Yes. We will do also for her ECG also because of this
Yes.
hypotension.
And
Okay.
painkiller, yes, because the differential diagnosis, central abdomen, maybe MI. Yes, what else?
Maybe pancreatitis.
Yes, maybe pancreatitis. Okay.
Maybe cholecystitis.
Maybe.
But yes, but there is no jaundice.
Yes, no jaundice. Yes. So you will now you wanted to start a supportive medication for the patient, painkiller and increased blood pressure, and then you will do targeted investigations, basic investigation and specific investigation. You will do ultrasound. No, gallbladder is normal. And what else you do? CBC, mild anemia.
Yes. The RFT, LFT, and also calcium.
Yes,
Electrolyte,
leukopenia.
sodium, and potassium.
Yes. What do you expect in the sodium and potassium in this case?
Mostly sodium will be low
Yes, sodium will be low. Yes. Why?
because of this hypotension.
Yes. Okay.
And also, I showed maybe she has autoimmune disease. I don't know.
Yes. So you will do a screening for this.
Yes,
Huh?
yes,
What you want?
anti-nuclear antibody,
Yes, anti-nuclear antibody. Good. What else?
anti-double strand
Yes,
DNA.
anti-double. Yes.
Okay.
C3 and C4 is
Yes,
selective protein.
yes.
Okay.
CRB also.
Yes.
Okay.
Only one question. If you ask this question specifically, you can reach to the diagnosis. What is this question?
Question for this patient only
Yes.
to reach. Yes,
Yes. If you
skin
one,
tightness maybe. Any
one,
skin rashes when the sun exposure.
you ask in the history, and I told you I don't have any joint pain, any skin rash. You remember?
Okay. Yes.
So skin is normal no, in this case. But there is one question. If you ask to the patient during the history, you will reach to the diagnosis of all this dilemma. Do you know what? Do you think what
No.
is? Okay.
Metabolic syndrome also can do the blood sugar and the blood pressure high and the
No,
weight.
no,
Okay.
no. Yes, yes, it can be like this, but it is not in this case.
Nephrotic also.
Yes, patient has nephrotic syndrome before.
Mm,
Yes.
yes.
Okay. I will comment in this case. عشان انت المره اللي فاتت قلت لي ده انت سرجيت طيب خالص يا ريت تكون معايا في الامتحان
لا
فاكر؟
كده كده غيرنا رأينا يا دكتور محي.
أيوة، أنا أقول لك يعني كان يعني المنتور اللي كان بيشرح لنا قال لنا when you take history for this for medication history you will ask show me your medication list so the
Yeah.
patient will give you all the medication you will ask target question do you use corticosteroid before by name you should ask يعني you ask anti-hypertensive anti but for corticosteroid you should ask by name do you use corticosteroid and this is the clue for this case this patient 2 years back developed flare or occurrence of systemic lupus erythematosus without skin rash not all systemic lupus patient came with skin rash and joint pain. There are many presentations for systemic lupus and embassies also in the form of maybe rise of body temperature, pyrexia of unknown origin, leukopenia, lymph nodes. Maybe the first presentation of systemic lupus is as this case, lupus nephritis. Patient came with fluorescent urine and dark urine, nephrotic syndrome, microscopic, hematuria and nephrosis, so glomerulonephritis. And this complicated nephritis by hypertension. They started for this patient cyclophosphamide and corticosteroid, and they continued in these medications and improved. Improved from muscle pain, from nephrosis, from lupus nephritis, from. But some complications of corticosteroid started to appear in this patient. Weight gain, rise of body temperature, body blood pressure, and rise of the blood sugar. So they started for here medication for antihypertension and for diabetes. Recently, 1 week back, patient did not receive corticosteroid. She stopped her corticosteroid for any cause. So developed flare of the systemic lupus erythematosus in the form of muscle pain and dark urine and become amount is low for the urine. And this patient also developed today, 10 hours back, Addisonian crisis in the form of central abdomen pain, vomiting, and hypotension. So this is the case. Okay, Dr. Ahmed.
Okay.
This case came before in Egypt, but the scenario was for systemic sclerosis. Patient came with abdominal pain to the in the exam, and my friend asked the patient, "Show me your medication list." He gave him medication, is cabotin, and for diabetes and for, but he did not. When he saw the bag of medication, no corticosteroid, and he did not ask by the name. Do you use corticosteroid before? He did not ask this question, and he lost the case.
So
And
it means in every patient we should ask regarding the corticosteroid, an indication like
according
this.
to, yes,
Mm.
and this patient also, patient on cyclophosphamide, this is chemotherapy medication, immunosuppressive. We usually did not give this medication for any patient except the patient has autoimmune disease. Okay.
Yes.
Okay, thank you, Dr. Mahi. It's a tricky case, or very tricky one. Plus, your internet connection also was tricky, so it didn't help Dr. Ahmed to ask the question. Yeah, it's okay. But the take-home message, as Dr. Mahi said, sometimes personally or specifically you have to ask about steroid in the medication list. But I believe even if the patient was taking steroid, it should be in the medication list. Maybe if you don't ask about your medication list, you will lose the case or you will miss the steroid. I don't know if they will not write steroid with the medication list. For what reason? Suppose write all medication patient has been taken for the last period. This is what I realize in experience. But to
يا
be
باشا
to be hidden,
مش الدايت اللي فاتت دي، الدايت اللي
yeah,
قبلها في
I agree with you. It's okay, but
قصر
to be
امتحان حاجه
hidden,
اسمها
it's
قصر القبه ده، ولا مش عارف، مش في امتحان كده هناك في القاهره في الحته
معادي
دي؟
معادي center
عادي.
or
معهد العسكري والقصر
القصر.
ايوه
العيني.
ايوه
القصر
Okay,
العيني ومعهد
okay.
العسكري.
I believe they can do it in a toxic way, just to pick up the question of steroid or to pick up the idea of steroid for the patient. But again, as Dr. Muhi said, this patient is complicated one with autoimmune features. So suppose this patient either he took the steroid, so you can specify a question for steroid, and it will refresh ourselves and our minds to ask this question, particularly when you have such symptoms. Abdominal pain, hypotension, severe hypotension while the patient was hypertensive. There's something weird. You can ask this question particularly with the patient for long-term use of steroids, like SLE or vasculitis, and also for COPD patient on steroid for any reason. You have to ask about steroid. You have to guess it first. Of course, you have to suspect this patient on steroid.
was why patient weight gain in one year back,
Yeah,
why start blood pressure raised on the. If you ask also, do you have any back pain? Yes, because any patient with on
osteoporosis.
steroid,
Hmm.
yes, it should be examined. Even patient has no complaint, you should examine the back, lower back, because this.
Yeah. Suppose also abdominal pain of unknown reason with hypotension, you can suspect a dystonia crisis on the top, of course, on background of high steroid intake. So you can suspect this strongly. Plus, I think this patient gain weight with normal appetite, right? You don't, Dr. Ahmed didn't ask about the appetite or the
Not ask.
appetite. Yeah. Try to ask the question together. You ask the weight, but you didn't continue asking or analyzing the weight gain. I think this time also the internet disconnected. That's why you lost this area of history. So supposed to ask about the gain, the weight gain, where exactly? I think this time the internet dropped. I guess so. So you didn't know where exactly this weight. Is it all the body, or in the mouth, in the neck only, or in the back, the tummy? Whenever you have weight gain, you have to analyze where exactly. And when you know where, you have to ask for the other manifestation of, for example, cushingoid features. So in this scenario, you will have increased weight or gain weight, particularly in the back, interscapular, as well as the tummy. You can add some question for that in Istria, but I guess you asked about the OSA as a complication. You didn't ask particularly about the steroid manifestation or cushingoid manifestation. You focused on the OSA, obstructive sleep apnea, right? You asked him about snoring, he
Yes.
told you, but why?
First, I thought it is hypothyroidism on the start.
Yeah, you tried to ask about the association or the complication of the obesity, but you didn't, or the weight gain, but you didn't know the cause. That's why you are lost. If you ask about the stria, easy bruises, he might give you the case. I think so. Dr. Mahi supposed to say about this manifestation if you ask it, particularly about the cachinoid. I mean, anyway, as Dr. Mahi said, the take-home message from this scenario: try to ask about steroid as a medication separately. When you have weight gain, when you have other manifestation of cushingoid. By the way, if you examine this patient, supposed to see in his tummy the stria, supposed to find the interscapular fat deposition, and in the face as well. Mio might have bruises, suppose as well, but I don't know if Dr. Muhi can show us this manifestation. If you ask about, was it there, Dr. Muhi, as a
He
cachinoid?
did not,
Yeah, I
he
know he
didn't ask,
didn't. Yeah, he
yes,
didn't.
if he asked for hirsutism or change in the face,
Yes, exactly.
Dr. Ahmed really he asked me where you put the weight, and I told him in the whole body, and I don't want to say by name trunk. I want,
Yeah.
yani, but
Okay. But to be in mind, cushion with immunosuppressant medication, supposed to think about steroid intake. This is a very important message from this scenario. Whenever you have patient taking cyclophosphamide as immunosuppressant medication for a long time, you have to suspect the steroid as immunosuppressant medication as well as the cyclosporin for a long time. So it's clear to be in the same group of medication. Plus medication list, I guess they will not hide this medication unless they want to fail all candidates, or they want to choose the most smart one to ask about this medication by name. But again, with the stress, if you didn't have any clue to ask about steroid, it's difficult to think about it by just thinking about steroid in the history. So it would be as a clue from other finding and other manifestation of cushingoid. Maybe you might pick up this from the features of the patient. Of course, it will be face to face, not in the online session. So whenever you look at the patient, you might know this is a cushingoid patient, and you can get the diagnosis or the clue. Maybe also during doing the examination. But once you went to examine the patient, you might uh, you might not have the time to ask back the patient about the steroid, or you can ask in quick manner before the concern. Have you ever take the steroid? Yes. So you can suspect the Addison instantly in the same time before the concern. Then you will get the case. You can answer the differential. You can give the Addison as a cause of this presentation. Even if you do that, you can get the mark. You get it, Dr. Ahmed? I mean, even if you didn't gain it from the history, you can get
Yes.
it from the look, even though you can get the full mark when you mention a dystonia crisis to the examiner. Even if you forget or if you didn't give impression to the patient, this is a dystonia crisis. Maybe you will collect the thoughts, You will link the scenario, you link the symptoms with the finding during examiner discussion. You can give, at least give to the examiner the clue that this is a dystonia crisis, better than nothing. Okay, but it would be perfect if you mention to the patient, this is because of, for example, stopping abruptly the steroid, which is supposed to be taken in regular and compliant manner without stopping, or even decreasing unless you have advice from your GP. So this is the case. Again, it's a tricky or very tricky case, but at least if you know it one day, you will know it permanently. Okay, any question, Dr. Ahmed, Dr. Mahi?
No, thank you, doctor. Appreciate it
كنت عايز
really,
اقول
Dr.
بس
Bas. Thank you, Dr. Mohammed.
Yes. Okay.
systemic
Okay.
lupus
Yeah.
erythematosus, it is not only to come with joint pain, skin rash. It can come with it has many features in presentation. Maybe patient came with only fatigue, and when you did CBC, you find leukopenia. So this is one presentation. It may be presented also with as our case today, microscopic hematuria and lupus nephritis, glomerulonephritis. Maybe patient presented with um, uh, lymph node also. Maybe presented, the first presentation of systemic lupus is miscarriage or pulmonary embolism or DVT. Or sometimes it can be presented with arterial thrombosis also. No skin rash, no. And maybe also the fifth presentation is patient came with photosensitive rash only. So many presentations for systemic lupus to think in. Maybe also presented with pyrexia of unknown origin. We can looking for pyrexia and thinking in malignancy, thinking in infection, and the case is systemic lupus erythematosus.
Yeah, this is explain also why this patient gain weight. Suppose SLE patient as a connective tissue disease, he will have weight loss, but maybe because of the steroid intake, he gained the weight.
Dr. Ahmed, during the history, he asked me, what was the diagnosis at that time?
Yeah,
I-
good, perfect question. Yes, but
Yes.
never, ever the surrogate will tell you. He will tell you, I don't know. He will tell you, I cannot remember. Because if he give you the diagnosis, you will catch the case. So don't wait for the surrogate to tell you this. However, it happened. I think it happened maybe because of immature surrogate. Some in some center or one diet, the surrogate give the name of the disease initially. So by mistake, of course. Then the examiner shouted at her, "Why you said this?" Maybe the candidate was sitting there, was lucky to know or to hear this diagnosis, and he catch the case by this word.
But they have not deducted the marks from him.
No. This is not our problem. This is surrogate problem. They cannot
Yeah.
deduct. I reached the diagnosis. They give me. I hear the clue. This is not my problem to hear it from the surrogate or immature surrogate.
We need these surrogates in the exam.
Yeah, in my FMF scenario, I remember also it was like a mistake. When I asked about chest pain, the surrogate denied. She told me, no chest pain. Then the examiner shouted at her, how there is chest pain? So I realized there is chest pain. I analyzed it, and it was sinusitis for FMF patient. What I mean, the surrogate sometimes helpful, maybe by mistake, maybe also distracting you by mistake. Maybe they will be following the instruction tightly, and they will help you either to reach diagnosis or to distract you. So it depends on the surrogate maturity or experience in basis. Some of them new, some of them already practiced before as a surrogate. So don't wait.
I think, yes. Dr. Bassam, I think we need also this examiner to be concentrating on what the surrogate telling. Maybe
That's
if
why
not concentrating, it will be a
exactly.
problem for us.
That's why I'm saying it's examiner wish and lucky day. the examiner need to be concentrated with your question, with the answers, with the address the concern. It's a matter of luck from A to Z. From you enter, since you enter the station, till you tell him thank you, goodbye. It's a matter of luck how he judge on your performance from Allah. So pray for this to happen, to be having a good examiner with good focus, but with the good things, not with the bad or with the missing point.
We hope, inshallah.
Inshallah. Okay, any question, Dr. Ahmed, from this case or previous?
No, appreciated really. Thank you, Dr. Mohi, for this case, and thank you, Dr. Basim.
Most welcome, Dr. Ahmed. Any question, Dr. Mohi? Any suggestion? Any missing point? Okay, any question from others? Any discussion? Any point to be discussed? Any
Just
doubts?
from your experience, Dr. Basim, regarding if we have acute patient like this, because I don't know even the cardiac condition of this patient. I will start a normal saline, or what I will do in acute situation like this in your
Yes, Addison
experience. Yes.
crisis, you should start 1 liter, running 1 liter, fast drip, as you suspect Addisonian crisis. Then, according to the blood sugar, if there is hypoglycemia, because Addisonia associated also with hypoglycemia, you can
Yes.
give him D5 normal saline, I mean. But the best solution and the best fluid to give is crystalloid in the form of normal saline, 1 liter, fast drip.
So I will start that. I said I will give the IV fluid in this situation for the patient,
Yeah,
or taking the
it's
history and this. Yeah.
it's good to mention that. Yes, I agree to say, is the patient stable? How is the patient now? How the vitals? But don't waste a lot of time, because I think you spend 2 minutes asking how is it and how is the blood pressure, the vitals. So just assure
Yes.
that the patient is fine, the blood pressure is okay now, because I read in my note, it's a matter of show. I am showing the examiner that I am careful about the patient vitals. So I will tell him, how the vitals now? Is he fine? So I have a look to the patient. If he's fine, we can take history now in this way. So you show the examiner that, because they will not give you patient with severe hypotension. Yes, it could be in the paper, but in the examination time, he will tell you borderline blood pressure. It will not be hypotensive, because they will not bring patient severely hypotensive in reality. Suppose this patient would be admitted to the ICU. What other medication you will give for this
Yes.
patient is important, Dr. Good to remember this point. Now you know this is Addisonian crisis. What you want to give, apart from the fluid?
Hydrocortisone, I think.
Exactly, yes.
Hydrocortisone.
Exactly. A high dose of hydrocortisone, 200 maybe, then followed by 100 milligram Q8 hours for the replacement. And the patient supposed to resume his steroid intake as daily basis. Plus the education, counseling about the medication, the side effect of steroid, and the importance of the compliance, not to be withdraw again or to stop the medication by himself again. All these things will be very important, more than the pharmacological option. So we'll start medication, ask management as the non-pharmacological, more importantly than the pharmacological. Of course, the pharmacological is important in the form of steroid, but the compliance to the steroid is much important than the steroid itself. And the side effect as well, because he has some osteoporosis and other manifestation of thyroid, cushingoid, so need to be educated well. Okay, show the examiner that. But it's good, again, it's good to show the examiner that, yeah, that you are caring about the patient stability. Is he stable? Can we assure that he's fine? Does he need anything to be given? For fever, does he need some painkiller, antipyretic, paracetamol? For the headache, shall I give him paracetamol? How is the headache now? All the things make impression to the examiner that you are careful about the patient. Okay. Any other question,
Okay.
Dr. Ahmed?
No, nothing. Just when I see there is headache and there is vomiting, I thought also there is increase intracranial tension also, but
By
there
the
is
way,
no glare.
yeah, it's good to think about it, but supposed to be rolled out because of the hypotension. I suspected I suspected as subarachnoid followed by pituitary apoplexy. This is what I suspect because the patient was hypertensive. Suddenly he became hypotensive. So maybe it was pituitary macroadenoma followed by subarachnoid and pituitary apoplexy after the panhypopituitarism or the pituitary gland failed. So it's one of the possible scenarios, by the way, to have the patient with severely hypotension. Okay, but the same idea, low cortisone, but different pathology.
Yes.
Okay. Any other question? Any comment? Okay, let's see the comment in the chat box. I think no one commented. Dr. Marwa just okay. In this case, steroid may be a cause of peptic ulcer and similar presentation, but with melena or vomiting of blood. Exactly, it would be, and I should roll it out. Severe tummy pain and the epigastric area associated with vomiting of blood, and maybe preceded with black stool. Good to mention. Thank you, Dr. Marwa. Okay, any other question? Clear for all? Hopefully you understood the case well. You learned the message today and you learned the lesson. Always ask about steroid if you suspect cushingoid or something related to the steroid intake. And as well for the medication list. It might be there in the list, and once you find steroid, you have to address it. Plus, the non-steroidal anti-inflammatory. This is the most important medication you might find in the medication lists, and you have to address them. You have to ask more about them. Thank you, Dr. Ahmed, Dr. Mahi, for the practice today.
Thank you, Dr. Bas.
Thank you, everyone. I guess no more comments. No one is raising the hand. Anyone want to add comment? Dr. Aisha, Dr. Rasha, anyone? Feel free to add. Even we mentioned something, you can repeat it, or you can add something before ending the session. Okay.
No, thank you, Dr. Bas. Thank you for.
Okay, thank you, Dr. Aisha. I will see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam.